So good evening to all. We will start with drug therapy of hypertension. See the principles. Let us think about physiology a little bit and then go to the real scenarios, okay, about the drugs. So the principles are mainly for hypertension. First of all, physiological BP is controlled by cardiac output into peripheral vascular resistance. So these two are the mainstay. So we should know where physiologically they are attacked and normally maintained, so that any alteration in these factors can bring about both rise in BP as well as fall in BP. This is physiological. And even lifestyle modifications also, we can make it physiological or in day-to-day life. Like as and when we proceed for age, we can cut down salt, we can try to walk or maintain the same weight right from almost 25-30 years to the last time. All those things can be made provided we are determined only. But in today's world, it is not so because of our parties and workouts and the way we live, the way we are in ITs, and there is no respect, no responsibility, and all those things. With that, I don't think we can have strict lifestyle modifications. And there are, from youngsters, there are question backs. Why we should do this? If you don't do, what will happen? All these are the questions which has to be answered. So physiological things should be known, including chronopharmacology, the timing of the action of certain areas, so that we can tell that drugs are targeted at those areas at those proper times, so that the blood pressure is maintained. This, as you know, it is a silent killer. So because it is a silent killer, we have to be more of preventive measures than of drug treatment. But when it comes to drug treatment, we have to suffice with a single drug. If not, today is the fashion of combination therapy, because two different mechanism of actions, then two different areas are targeted, and two different drugs when we put the decrease adverse effect. So many combinations and permutations are there. We will see to it one by one. But better not to go to drug treatment and look at the physiological levels and also lifestyle modifications. Whenever we are eating, have 8 hours gap or 10 hours gap, and when we eat too many junk foods, cut down it for 2-3 days. So all these are the things what has to be looked upon constantly to have a good lifestyle and see that we are not attacked by any of these non-communicable diseases, so that we can lead a normal life at least till 60. After 60, God Himself has made us some of the little more alterations where we can modify it according to that. As our ancestors used to say, after a certain age, eat only once, eat very little in the evening, don't take too much of salt. And accordingly, people were there at home and we used to get only certain types of works. All those are there, so it used to get managed. But now, being a very family which is very secular and only parents and children are there and everything should be done by themselves and all those things, we are facing a lot of problems with this. And so invariably they'll end up in drug treatment than the prevention, though motivation is done by various programs right from individual level to WHO level. Okay, see, these are the minor things what we have to know regarding the principles of hypertension. Now, there are varieties of hypertension. I think before this, let us go to this one, this slide. Okay, I think the upper one, if it is taken out, see. Okay. See, these are the some of the control areas. The first one, then physiological mediators. How these are balanced, we will see. Later on, we'll come to normal blood pressure, how it is balanced by various mechanisms. Then we will see which drugs are acting at what level, so that if we know this basic thing, whenever the patient comes to you at certain age groups or with hypertension per se, or with comorbidities, or with any congenital anomalies, we can certainly alter many of these. So the areas which control our blood pressure are mainly four in nature. Presynaptic alpha-2 receptors, which are present in the brain. The next one is beta-1 receptors in the heart. Next is blood vessels. Next is blood vessels where there is alpha vasoconstrictors are alpha 1 calcium channels mainly, and vasodilators are beta 2 nitric oxide and potassium coming out of the cell, coming into the cell. And lastly, we have renin-angiotensin-aldosterone system. So what is happening in day-to-day life? Stimulation of presynaptic alpha-2 receptor centrally, physiologically. When it stimulates alpha-2 receptors, norepinephrine is released and it acts on alpha-1, alpha-2, beta-1, where there is a decrease in amount of norepinephrine to the periphery, where the actions on alpha-1, alpha-2, beta-1 is decreased, and so there is basically a fall in blood pressure. When the heart is stimulated, beta 1 is stimulated, like when you want to rush to a bus or to a working place and the time is very less, or when we want to meet our elders, or when we are facing an interview, viva, and all those things, beta 1 receptors are stimulated. As I told you in the last class, two main things you should remember for beta 1 to act. One is increase in heart rate, which will increase the force of contraction. With that, all the rest of the things will happen. So increase in heart rate will lead to increased force of contraction, increased cardiac output, increased left ventricular end diastolic pressure, volume, systole and diastole also. But the problem is there is decreased flow to the coronaries, because the flow to the coronaries is always during diastole. So these are the problems, and hence there is increase in blood pressure, where we saw the reverse in the central mechanism. The third, there is always a balance in the blood vessels, because we have both vasodilators and vasoconstrictors. So normally it is balanced, but if alpha 1 or calcium channels are more and it is stimulated, then there is vasoconstriction, increased total peripheral resistance and increased BP. And opposite vasodilators, if you are very cool and beta 2 is not touched upon, so accordingly vasodilatation occurs, including nitric oxide. And potassium is pushed into the cell, there is a hyperpolarization and hence decrease in blood pressure. Where normally in the blood vessels it is trying to maintain, provided there is any problem in the arterial or in the venous which leads to derangement. The main the main working area lies in the renin-angiotensin-aldosterone system. Renin is stimulated only if there is decrease in blood volume. So whenever there is decrease in blood volume, when renin is stimulated, it stimulates angiotensinogen, which stimulates angiotensin 1, which gets converted to angiotensin 2 by ACE enzyme. This same ACE enzyme will stimulate bradykinin, which can lead to so many other things that side. And here angiotensin 2 is 80 times more powerful vasoconstrictor than alpha 1. So you can imagine how alpha 1 in the blood vessels act and how angiotensin 2, when it is stimulated through various mechanisms, how does this act? Not only it is a very powerful vasoconstrictor, no, but also it stimulates aldosterone. Both put together, there will be increase in blood pressure. The aldosterone will increase the sodium and water retention or volume, and aldosterone being a very, very powerful vasoconstrictor and also a mixed vasoconstrictor, unlike the other things where only single things are stimulated. Here, angiotensin 2 is a mixed vasoconstrictor which will stimulate both arteries and veins and hence increase preload and afterload. When both are increased, directly there is an increase in blood pressure. When this works on the heart, when preload works on the heart, there is increased LV, EDP and volume. And outside, that is output, there is again increased pressure and volume. Both put together, what happens? Increased cardiac output, force of contraction, decreased flow to the coronaries. Over a period of time, what is happening? Remodeling will occur, fibrosis will take place, and programmed cell death will take place, because that amount of pressure heart is unable to withstand. And also the blood flow to the coronaries also is decreasing. All these put together, the heart might suffer from any of the cardiovascular diseases. Not only this, parallelly there is sodium and water retention, blood volume also increases, and together with that there is increase in the glomerular filtration rate, but the filtration per se might decrease. So added to that, there is further blood volume retention or fluid retention, which will cause increased blood volume. So all these put together, there are about 3 places where there is increase in blood pressure and only 2 places where it can decrease blood pressure in the normal physiological system. So this has to be balanced together with our lifestyle modifications, so that we should never undergo stress, we should never smoke, we should never have alcohol, or we should never be in a hurry. All these, or we should never eat too much of salt, we should never be obese, we should try to balance our weight, we should try to balance our diet. All these are the factors which are influencing these things and trying to maintain normal blood pressure as such to have a healthy life. This is about physiology in a very short term, to understand how blood pressure is maintained and balanced so that we can target the drugs at various stages. Now, coming to the drugs, before that, I want to tell you a little about the age-related thing. I didn't put it here. I thought I'll tell you this. Age-related thing, you can group it into 4 areas. Persons who are somewhere around 30, 35 and below. Individuals who are between 40 to 60, and then 60 to 80 and above 80. Below 40 or 35, sympathomimetic activity is at the highest. So we have to cut down that sympathomimetic activity to decrease the blood pressure ultimately. Whereas 40 to 60, all said and done, we want cardiorenal protection. So we have to target at those places. Above 60, physiologically only the elasticity of the blood vessels is lost, and so the arterial elasticity will increase, raising the systolic blood pressure, what we call as isolated systolic hypertension. 2.5 decades ago, when I started studying MBBS, this isolated systolic hypertension was never the term, and they also considered it as physiological. Suppose the age is 60, blood pressure is 160 by 80, we used to consider it as normal. But now it is not so. Even systolic should be decreased and the blood pressure should be as low as possible, preferably below 130/80 or 140/80 according to American and European guidelines respectively. So this is about isolated systolic hypertension, normally which occurs between 60 to 80. Above 80, according to me and so many other places, no drug is needed. But because the patient would not walk, would not do anything, patient will be sitting, there will be a lot of edema. That will increase the blood volume. So you have to take care of that so that you might reduce to a certain extent that blood pressure. Accordingly, you will put those drugs. For example, below 35, sympathomimetic activity is increased, so preferably beta blockers with nitric oxide activity. And 40 to 60, cardiorenoprotective ACE inhibitors, ARBs, together with diuretics. Isolated systolic hypertension, calcium channel blockers, that is dihydropyridine, not the non-dihydropyridine. And last, above 80, because of edema, come back to a small dose of diuretics, because we have to think about electrolyte imbalance, metabolic disturbances, organ toxicities, and all those things. Together with that, comorbidities, what is prevailing in the person. So this is a very convenient method of dividing the antihypertensive drugs to remember for practicing. To write in an exam, the same old system continues as in the textbooks. But here, I have made it a point to write it according to the practice, and amongst them, the first word I have written comes in the last. Clonidine, this is never used at all, but if at all we use it as a fourth or fifth drug of choice in normal combination therapy of hypertension or in resistant hypertension. And methyl dopa was the drug of choice in pregnancy-induced hypertension, but now it is no more used because of so many adverse effects and also non-availability. So I think this chart, if you remember permanently, I think for the lifetime of the doctor, one can practice very easily and target at various places so that the patient who comes to you can lead basically a near normal life, but not what God had given. So we can bring it to near normal life and say that he is peacefully living for the rest of the time. Okay, with this, I'll go back again. With that, what happens? That is a physiological one, and hence when it rises, we will put them on the drugs. So this rise of blood pressure, everybody says I have BP. Everybody has BP. Only when it is more than 140/90, we call it as hypertension. So previously in our clinics, we used to do 2 or 3 times in 1 week or 2 weeks and brand them as hypertension with symptomatology. But now we have got varieties nowadays. We have got varieties, and so this ambulatory monitoring has become more common than office-based monitoring. So accordingly, we have placed it as white coat hypertension, where it is persistently elevated office recordings, but office readings, but and normal out of office. At home, when they record, it is normal. When they see the doctor, it is raising. All of them are at the hazard and risk of both cardiovascular disease, cerebrovascular disease, and sudden cardiac death, as well as target organ damage. But we can control, because the patient himself is knowing. When you tell them, when you teach them little bit, they will also come to know, and accordingly, they might say, today I have taken more salt, so let me decrease. I think I have increased in weight, let me do some exercise. So that sort of awareness is created when you divide it this and you tell them these are the names of the various names of hypertension what we have today. Masked hypertension, normal office. When the doctor records, it is normal, but at home or office, a working place, when they record, it is elevated. Maybe due to stress, or what we call normally called that fancy term nowadays. Morning surge within 2 hours of awakening or ambulating, which is normally common. Why that occurs physiologically, both sugar and BP, for the person to work. Body themselves, the internal body itself makes ready right from 4, 5 o'clock to 7 o'clock, so that sugar is also increased and blood pressure is also increased. By that physiological mechanisms, it is trying to come back to normal. Even in presence of that, if there is increase in blood pressure above 140/90, then we are afraid that there are increased risk of MI and sudden cardiac death. So you have to place the drug accordingly. The last one is persistently increasing at whatever time you see, wherever you see, and there is variability throughout the day, where we fear of target organ damage. So these are about 4 or 5 types, where you can sit with the patient and tell them, so that they are quite aware of this, and most of the problems are solved to a very great extent. Now, coming to hypertensive mechanisms, as I told you, I have put it in the chart so that you can remember. Here, this is multifactorial origin of hypertension. We have come to the real, what to say, like various mechanisms where we teach in the class or whatever it is. Like central, where I have shown central mechanisms, heart, then maintenance of sodium is retained because of aldosterone, and low renin activity will increase both sodium, calcium, and renin. And also blood vessels, there might be vasoconstriction as well as vasodilatation. These are the mechanisms what I showed you in the chart itself. This is the picture depiction. Now, how will you, just a scheme for this, so that you will understand the various drugs which are targeted at various areas. So this BP management, initially we will tell them to record 3-4 times, and then look at the symptoms, and then we will decide. If it is persistently, according to my practice, I tell them to record at home or at place. They should be normal, they should not be stressed, and at least a week they should record 3 to 4 times a day with the timings and with pulse rate. So when on an average, if it is more than 140/90, on an average, all put together, then we brand them as hypertension accordingly. Otherwise, if they are in the borderline, most often I tell them to have lifestyle changes, 2 hours of walk every day, no salt. If we say no salt, our Indian mentality is no salt, put quarter. If it is quarter salt, then they'll put half or one. Or if we say no problem with salt, they might put even a handful of salt also. So for that reason, no salt, 2 hours of walking, or half an hour of exercise, and then low fat, and don't eat too much. You eat as though it is half stomach full so that you can have one more morsel at any given time. So these are some of the things what we say. Why we want these lifestyle changes? There is total risk and target organ damage like LVH, left ventricular hypertrophy, post-MI, high coronary risk, heart failure, stroke, transient ischemic attacks, and chronic renal disease. So, because of all these fearing things, we want a goal or a target. So, when it is below 140/90 or below 130/80, when there is no compelling indications, we do not put them on the drug. Instead, I tell them, you keep on recording at home and in the office, you come every 15 days for 4 or 5 times. We will match both of them and see that whether we will brand whether you are in hypertensive or not. If it raises further, then we will have one drug or two drug combination. Then if we have not reached within 2 to 4 weeks, the necessary goal, then we go on adding 1, 2, 3 drugs. We move to 2 drugs more rapidly with different mechanism of action so that we will not have any target organ damage. This is the idea of combination therapy, not to have high risk at any given places. More so today, we are bothered more about diabetes, chronic renal disease, and CV risk. So, according to these, we try to have this PP management clinically, practicing types. Okay, so you add with different mechanism. You should have in your mind different mechanism of action 1 and decreased adverse effects, or adverse effects should be nullified when you add 2 types of drugs. So this is how we do it in a clinic setting, not hospital, clinic setting. Now, we will go to different types of antihypertensives at different sites. Then I'll go to the individual ones to tell the important points only in hypertension, because all these drugs are used in various places. That itself will take 1 week to tell for each drug. So these drugs, when used in hypertension, how do they act? What are the benefits? Why we are using? At what place we are using? At what age we are using? All these in combination, I would like to explain each one of them with very minimum time. Okay, as I told you, I have divided it according to the age and according to area. Now, the typical textbook definition where we have centrally acting agents, clonidine, reserpine, and moxonidine. Reserpine is no more used because of adverse effects. Then we have aldosterone blockers. Nowadays, we call it as mineralocorticoid receptor antagonists. These diuretics means in chronic hypertension, it is hydrochlorothiazide or chlorphalidone or indapamide. The others are not used. Metazolone only in CCF. Furosemide very rarely when hydrochlorothiazide does not work or when other antihypertensive does not work. The main drugs which are used are low dose hydrochlorothiazide and MRAs, mineralocorticoid receptor antagonists. Next, catecholamine inhibitors, both alpha and beta. In alpha, as I told you in the last class, prazosin mainly, and beta, we have several drugs. Most often we try to use drugs with nitric oxide activators, that is nebivolol, carvedilol, and bisoprolol. And later on, looking at the other comorbid conditions, we would like to add metoprolol. The vasodilators, here in DHPs, mainly nifedipine, amlodipine, which are used orally. Nifedipine can be used in hypertensive crisis as crushed tablets. But in chronic, normally we use amlodipine. Nowadays, cilindapine, because it has got actions on all the channels. And the clevidapine we use as first drug of choice in hypertensive crisis nowadays, where it was sodium nitroprusside till such time. Verapamil, diltiazem, they are not very good drugs for hypertensive. Instead, they are very good drugs for PSVT as well as angina. Not even angina, so to say PSVT. Diltiazem is a neutral drug where we can use in all 3 conditions. Prazosin, it is a last drug of choice like clonidine in hypertension. And it has got an additional activity which is cholesterol friendly. Hydralazine, these directly acting vasodilators, we do not use in our practice. We normally use it in hypertensive crisis because they are direct vasodilators either through potassium channels, mainly through potassium channels. And they have, because of that vasodilatation, there is tachycardia and fluid retention where we have to use 2 more drugs, which leads on to polypharmacy and their own adverse effects and other things. So because of these things, we We dare not use these drugs when we have better drugs, which we will see now. The most beautiful drugs amongst the antihypertensive drugs are ACE inhibitors and ARBs. So they inhibit accordingly ACE enzyme, converting enzymes, where it will not bring about angiotensin 2 itself, or angiotensin receptor blockers where they get attached to AT2 receptors. But both of them ultimately cause the action of mixed vasodilatation. So these are few drugs which are used normally in various combinations or as a sole drug where we want to protect the major organs, and hence the patient should lead a normal life, where we used to see hypertension leading on to CCF with alternative drugs in the general ward, alternative patients in the general ward about 3 decades ago. But now we do not see, because of these effective antihypertensive agents, which are cardioprotective in nature, and we can use it in almost all the diseases because they do not interfere with other organ problems. So any comorbid conditions, we raise our hand for ACE inhibitors and ARBs. Now, we are more bothered about heart than the other organs. So how hypertension affects the heart? Okay, so lipids, smoking, diabetes, these are the lifestyle problems where we have, and hence we have the vasoconstriction because of so many things, insulin resistance, etc., etc. And hence there is because of increased lipids, there is accumulation of LDL and other things where it causes vasoconstriction, and hence leads on to right from acute coronary syndrome to ischemia to infection. This leads on to neurohumoral stimulation, both centrally as well as peripherally, which leads on to diastolic dysfunction and left ventricular hypertrophy. Prior to that, there may be systolic failure also, and it will further damage the kidneys by causing vasoconstriction in the blood vessels also. So also in the brain, due to stress, there is more release of these central mechanisms, central activation systems are more. So all put together, there is major effect on the heart, which may lead on to even sudden cardiac death in many cases. But now, because we have got that awareness, these things are not seen to a great extent, but still we see, because though persons or individuals are educated, they are not educated health-wise. They are educated money-wise rather than health-wise. And so still we see more than mortality, we see morbidity in many cases. And to lead a life with morbidity is more difficult rather than mortality. Now, coming to each drug with respect to hypertension only. Please remember, I am talking only with hypertension and the mechanism of action, and a little bit of side effects, so that can we administer or not. So these are the things what is focused here. Okay, so diuretic effects of these diuretic mechanisms. Normally, juxtaglomerular cells, in that we have the both afferent and different, where there is glomerular filtration, and renin release will occur only when there is volume depletion. And then obviously these will increase renin secretion, which will result to angiotensin 2 together with aldosterone, causing vasoconstriction. So blood pressure will try to increase. These diuretics, they mainly act on the distal tubule. They act on the distal tubule, and sodium and chloride absorption is hindered. So once these are hindered, less sodium is absorbed. Whenever sodium is not absorbed, water is also not absorbed. It is both natriuresis. It is not just sodium going out of the body. Together with that, water also goes out of the body. This is the acute effect what we see with diuretics, especially the one which works on distal columnar tubules, that is hydrochlorothiazide, chlorthalidone. So these two are the major drugs what we use in most of the places, especially in hypertension, in low doses, where we are more bothered about those electrolyte imbalance and metabolic disturbances, which we will not see when we add very little lowest dose of the drug. The most important part of these drugs are on a long term. especially after 2 to 4 weeks, they have got vasodilatory effect also. That is the most important thing of these diuretics, which has made us to use this almost in conjunction or together with ACE inhibitors or ARBs. So here two different mechanism of actions. Sodium overload is also decreased, together with that blood volume is also decreased. But we have to see more about the adverse effects also, which are electrolyte imbalance. All are decreased. Hypokalemia, hyponatremia, hypocaloremia, hypocalcemia, hypopotassium, hypokalemia, all 5 electrolyte balance is decreased. Then we have metabolic disturbances, mainly hyperglycemia as well as hyperuricemia, and organ effects like ototoxicity and nephrotoxicity. So these are the major things which are bothersome for these diuresis. So when we use it at the lowest dose, what is that lowest dose? 6.25 to 12.5. We see wonderful effects of diuresis as well as vasodilatory effects than the adverse effects, and hence we stop at 12.5 milligrams as a sole agent or when we combine with ACE inhibitors or ARBs. What is the helpful thing? ACE inhibitors and ARBs, as I told you, they act at respective places and cause mixed vasodilators. And together with that 8 or 10 words, what I told you, they will protect the vessels, heart, coronaries, everywhere. They will protect both cardio, renal protective. But the problem here are 3 main things observed in clinical practice are dry brassy cough with ACE inhibitors, and 2 others with both of them, that is hyperkalemia and first dose hypotension. This dry brassy cough, you should not bother much and tell the patient that you wait for 3 to 4 weeks. Patient will get tolerance to that. Still, if no tolerance, then you switch on the drug to ARBs or otherwise. First dose hypotension is combated by giving the drug at night. Moreover, RAS system is activated in the evening and night. So always start the ACE inhibitors and ARBs at night. But none of our doctors follow this. Straight away they put the drug in the morning. When they put the drug in the morning, look at the fun in it. When they put the drug in the morning, plasma half-life is about 4 to 5 hours or maximum 6 hours. Half of the drug would have got excreted. By the time RAS system is active, not even half of the drug is in the body. So how much it can block, you can imagine. But they come back saying that though you have given such a drug, such a costly drug, BP has not come back to normal. We are not putting the right drug at the right time. When we don't put the right drug at the right time, what can happen? Obviously, the drug won't work and there is therapeutic failure. So please see the chronopharmacology, that is timing of the drug, and you should block physiological. Only then there is the effect of the drug what you use. Otherwise, even if you put 5 drugs, the hypertension is not decreased. With that, the patient will go for window shopping. Today is the day where you have to retain the patient 100%. Otherwise, they will do window shopping. So please know chronopharmacology. In that, you can make out every aspect of these things. First dose hypotension, you start at night. By the time it is morning, half the drug would have got excreted. So you are quite safe. Hyperkalemia, because in conjunction with aldosterone, because sodium and water excretion happens, so potassium retains. So hyperkalemia will be there. Most often this occurs only after 2 weeks. So get done serum creatinine and potassium levels after 3 weeks. Ask them to come at the end of 2 weeks only, because when they come, it will be 3 weeks. Okay, and tell them to come promptly. Explain them that this drug might do, though it is a wonderful drug doing 200% positive, but there may be 25% negative. So for that reason, please come back, get these 2 investigation. We will adjust the dose of the drug so that you will never face any problems. These are the communication skills what you should have when you are treating a patient with ACE inhibitors or ARBs. Now, when you combine these 2 drugs, what happens? The hyperkalemia with ACE or ARB is combated by hydrochlorothiazide, which causes hypokalemia. And because of 2 different mechanisms of actions, you will see that the blood pressure is decreased enormously, and the patient can maintain with that BP. not having any further cardiovascular complications or other complications also. Next, coming to other drugs. Again, same, basically diuretics mainly here. The main thing will be sodium loss, which is again there will be a reactive increase in circulating renin, which will stimulate angiotensin mediated vasoconstriction to combat that hypotensive effect. So diuretics will combine well with beta blockers. Why? This will stimulate renin. Beta blockers will inhibit renin. This is one point. Next, with angiotensin converting enzyme inhibitors, angiotensin inhibit the formation of angiotensin 2 and with receptor blockers. And with calcium channel blockers, this diuretic induced vasoconstriction is combated by DHP CCBs. So combinations are very useful, especially with diuretic and AC inhibitors or ARBs. And hence, and also not only it is good in mechanism of action or reducing BP, but it also reduces the metabolic side effects of diuretics. AC inhibitors and ARBs do not interfere with in any organ, in any metabolic side effect. So whatever metabolic side effects are there with diuretics, when you put it on the low dose and combine with AC inhibitors or ARBs, you see to it that the maximum effect is produced. Thereby, you see that the complications of hypertension, which is a silent killer, is never there, and the patient can live happily with a single drug for next 30 or 40 years of life, what God has given to them. So beta blockade, I would like to say once more, because these are the wonderful anti-mortality drugs even today. But you should put it at the right time. So because of that, which has anti-mortality drug and which protects 100 to 200% in wherever you are, however you are, this drug should never be forgotten even in the worst of the dreams. Now, beta blockade, what does it do? It will block beta 1 receptors both in the heart as well as in the kidneys. In the heart, as I told you, there is decreased heart rate, decreased output, and when there is decreased renin, okay, renin gets decreased. Obviously, angiotensin might get increased, but there is an offset mechanism. BP remains unchanged when there is beta blockade. Later, on a long-term scale, when norepinephrine release is inhibited, the systemic vascular resistance falls, and after 2 to 3 weeks only BP will fall. That is the reason why we have taken out beta blockers as first-line drugs in hypertension, because BP reduces only after 2 to 3 weeks. But still, this is a wonderful drug where the main effect of decrease in heart rate will protect the heart in various ways, and hence we see that this is the drug of choice at any given time. At any given time. These are the third drug of choice, calcium channel blockers, especially those acting on the blood vessels, that is dihydropyridines, starting from nifedipine, amlodipine, felodipine, cilindipine, clevidipine, then we have felodipine. All these are the drugs which are there, but normally we use amlodipine for chronic. Nifedipine we used to use, but we have to monitor blood pressure. It should be more than 190, and it causes tachycardia, sudden hypotension. So for that we use only in crisis or in PIH. But it has been replaced again by labetalol. And cilindipine is used mainly in diabetic nephropathy, and clevidipine is the latest one where we are using as in hypertensive crisis IV, and azlodipine is one more which is almost similar to amlodipine, but amlodipine acts only on L-type calcium channels, but azlindipine acts on all the three receptors, so that you are protecting both blood vessels, heart, kidneys, everywhere, and you see a better effect, and the diabetic nephropathy is decreased to a maximum extent. So all these DHP dihydropyridines acts mainly on the L-type calcium channels on the blood vessels, thereby causing dilatation of the arteries. They do not have diuretic effects, no counter regulation or stimulation of renin or angiotensin 2. So acute adrenergic stimulation is not seen except when there is sudden hypotension. This tachycardia might lead on to myocardial ischemia if at all, if there is a presence of coronary disease. Then don't add these calcium channel blockers, but you can add long-acting calcium channel blockers in the treatment of per se hypertension or with comorbidities. And inhibition of aldosterone obviates overall fluid retention. This does not interfere with that. We need not add also. And we can use as a sole agent whenever there is a blood pressure rise of systole and diastole being normal, which in most of the cases it is isolated systolic hypertension. Like for example, 160 by 70 or 180 by 70, 180 by 110. So when systole has risen, these drugs are very much effective and you can treat them at home. Instead of spending 10,000, you can finish it in 1,000 only. Ask them to have BP monitoring every 4 hours, every half an hour for 4 hours, every 1 hour for next 4 hours, every 3 hours for 3 days. And BP will have come back to normal. You put them on amlodipine 5 mg 2 times daily, and the bed should be near bathroom because when they get up, they should never have hypotension and they fear of edema. Calcium channel blockers are known to produce edema, a pre-tibial edema because it is pre-arteriovenular edema which doesn't subside with diuretics. It doesn't subside with diuretics. These are the reasons. And over a period of time, there is also tolerance when you switch them on to 2.5 mg, and it is a wonderful drug to decrease the systolic blood pressure mainly by inhibiting the L-type calcium channels, and it does not affect any other thing. Though it has got a very minor pleiotropic actions of inhibiting the aldosterone, very minimum action of diuresis, reflex adrenergic action, and definitely it produces tachycardia. Patient might come back and say that we can hear the heart sounds are in the hand than in the heart, and the non-DHP can inhibit the SCA node, causing bradycardia and even heart block also. But there is baroreceptor stimulation and systemic vascular resistance might increase because of renin stimulation. These are all very minor effects, and you can see a maximum beautiful effect in decreasing systolic blood pressure when we use these calcium channel blockers, and they are the wonderful drugs in patients who are about 60 years of age as a sole agent, Now, this is the magic drugs which has decreased the congestive cardiac failure to a maximum extent, both ACE as inhibitors as well as blockers. So these, when ACE inhibitors are added or ARBs are added, the sequence of events are the same, except that AC inhibition also blocks bradykinin. That's all. Otherwise, both of them have the same problem, same sequelae of events. You remember this and you make permutation combination with nitrates, calcium channel blockers and beta blockers. You can by heart all the pharmacological actions very nicely, understand very nicely, and you can put each drug at different patients at different time and play very nicely. And nobody can beat you in this regimen. Even the most best of the hypertensive specialists, you can combat them if you know these 4 drugs, the mechanism of action, and these 8 to 10 words properly. These ACE inhibitors and ARBs, they are all mixed vasodilators. That means they dilate both venules, veins and arteries, including venules and arterioles. Once both are dilated, when venules are dilated, preload is decreased. That is, the flow to the heart is decreased, and arterial afterload, that is, the output, cardiac output is decreased, systole is decreased, so afterload is decreased. Vascular resistance is decreased. So preload and afterload are decreased. When both of them are decreased, what happens? Flow to the heart as well as away from the heart, both are decreased. When both are decreased, what happens? Left ventricular end diastolic pressure and volume is decreased. Once the entry is decreased, cardiac output is decreased, force of contraction is decreased. When both of them are decreased and it has no effect on the heart rate, there is increase in the coronaries, indirect. Okay, because there is no problem in the heart rate, it also has got an anti-arrhythmic effect, if at all the patient is prone for. So when all these are decreased and increase in the coronaries, blood flow to the heart is increased. Because blood flow to the heart is increased, fibrosis chances are decreased, remodeling is decreased, and apoptosis is decreased. Because it decreases after load, that is flow away from the heart, systole is decreased, and hence the flow to the CNS through the carotids is decreased. Carotids are also enlarged, so flow to the brain is decreased. It is increased because of vasodilatation, and so perfusion is increased. So overall, without any other further adverse effects to the organs, you have got a wonderful effect, but only tachycardia is a problem. So start with lower dose, start at night. Many of the problems are decreased, and you will see a wonderful decrease of blood pressure. Also an advantage for the heart as well as the kidneys, and indirectly to the brain as well as to the eyes. So these are the advantages of ACE inhibition and ARBs. And so this is the first drug of choice. Closing your eyes, you can say antihypertensive drugs means ACE inhibitors and ARBs because of all these effects. All these 8 to 10 words are the same for beta blockers, nitrates, calcium channel blockers, and ACE inhibitors. So you just make some alterations, you will get the whole scenario, and you are playing with hypertension, beating the hypertensive specialist also. Now, I have completed the main ones. The rest ones are direct renin inhibitors, where we are using hardly these drugs. Okay, direct renin inhibitors, aliskiren, where we see renin is directly inhibited, but we have not found very good placement in our practice nor in the trials. Alpha adrenergic blockers, prazosin, we use it as the fourth drug. In the JNC guidelines and other things, we have made it as A, B, C, D. First, it is AC inhibitors or ARBs. Then you take from the other side C, calcium channel blockers. Then D, diuretics. After these, add beta blockers. But sometimes, as I told you, in younger patients, you can add beta blockers with nitric oxide activity. When 3 drugs are not sufficient and still the BP is more than 140/90 plus symptomatology, then you can go on for clonidine or prazosin. Okay, so this is the way we usually treat hypertension. So this is the last drug of choice. Direct vasodilators, prazosin, we are bothered about first dose hypertension, no tachycardia. It is cholesterol friendly. Hydralazine, minoxidil, we are really afraid of all these vasodilators. Vasodilators are divided into 3 categories. One is arterial vasodilators, prazosin, calcium channel blockers. Then venular dilators are nitrates, mixed vasodilators are AC inhibitors, ARBs, and sodium nitroprusside. And direct in arterial vasodilators, we have even AC inhibitors, ARBs, calcium channel blockers, prazosin, and hydralazine, minoxidil, as well as diazoxin. So all these directly acting vasodilators we fear because of side effects 1, and all these directly acting vasodilators, especially hydralazine, minoxidil, diazoxide, all these are potassium oriented. So they cause tachycardia, reflex tachycardia, and sodium and water retention. So you have to do a polypharmacy where there is adverse effect of those drugs also. So we dare not use this hydralazine and minoxidil. We fear hydralazine because of SLE, systemic lupus erythematosus, and minoxidil for hirsutism, where it is an off-label use for baldness. And diazoxide, the 4 words which are very, very important are diazoxide is given by IV fast bolus. IV fast bolus. Why IV? It is exclusively given by IV. Orally, it is not absorbed. And fast bolus, if you give slowly, it will have plasma protein binding. So for that, you have to give it as fast bolus. And it is always an IV drug. Diazoxide. Minoxidil, I told you, hirsutism, hydralazine, SLE. So we dare not use these drugs. Normally, we use sodium nitroprusside in hypertensive urgencies and emergencies. Now we have shifted. If it is a primary care, we use nifedipine. If it is a tertiary care, sodium nitroprusside, but it should be covered with black paper and monitored for 72 hours. So now we have come back to either clevidapine or even nicardipine, or sometimes we still use sodium nitroprusside. But if the blood volume is more with pulmonary edema, we prefer furosemide. Centrally acting adrenergic receptors, they are clonidine and methyl dopa. Mostly now we are very fond of off-label uses of clonidine or other uses of clonidine with the congeners of clonidine than clonidine per se because of its side effects. Alpha methyl dopa, we are fearing about Coombs test. Because of that, we will not use nowadays in hypertension because we have got better drugs like labetalol, amlodipine, etc. Now, here combined with patient profiling, how can we use in various diseases? We can't say, no, I'm not an hypertension specialist, so I won't use those drugs. We have to use it. We cannot say no. And nowadays, patient will have one or the other comorbid conditions. So I'll just name a few. You can think how it is used. If you get any doubt, you ask me back. Because I have explained all of them in detail. I think most of them I have explained completely. Okay. Dyslipidemias. Statins are the first drug of choice. Together with hypertension, we use ACE, ARB, CCB, which are lipid neutral. They will never decrease HDL or they will never increase LDL. So these are the things, and hence we use these drugs for as antihypertensives along with statins. In angina, beta blockers and CCBs. Beta blockers are contraindicated in unstable angina. CCBs are DHPs like nifedipine, amlodipine, cilindapine, nicardipine, nimodipine. All these are used. But nicardipine is also mainly used in subarachnoid hemorrhage. Post-infarct, beta blockers are the drugs which will survive. Anti-mortality drug together with AC inhibitors or ARBs. In all these cases, patient has hypertension with dyslipidemia, hypertension with angina, hypertension post-infarct, like that. Okay. In elderly 65 and above, low dose diuretics with ACE if at all prior hypertensive. But otherwise, in isolated systolic hypertension, CCBs together with lifestyle modifications, and do not lower diastolic below 70 at any cost. 160/70 is more grateful than 160/40. They may go on for septic shock, septicemia, and they may die. So because of that, always see to it. And for diastolic hypertension, again AC inhibitors or ARBs are the drug of choice, not the other things. In case of smoking, most often it is lifestyle modifications and stop smoking, because smoking itself will promote renovascular and malignant hypertension. In obese patients, again, along with lifestyle modifications with intermittent fasting and other things, AC inhibitors, ARBs, and diuretics are the mainstay. With metabolic, diabetic hypertensives, metabolic syndrome, or nephropathy, or exercise-induced, normally we use AC inhibitors, ARBs with low-dose diuretics. If not sufficient, we try to use cilindapine because it also protects kidneys. We should be more bothered about kidneys because they may come back with CKD. That's the problem. So for that reason, have an eye on that, and also add, we have got triple drug combination. So we can add CCBs, low-dose CCBs, most often amlodipine. Pregnancy-induced hypertension, the first drug of choice is labetalol, then amlodipine, lastly hydralazine. We have to take a chance because there is no teratogenic, because it does not cross the placental barrier. We take a chance. Otherwise, the drug of choices are labetalol, amlodipine, methyl dopa, hydralazine in pregnancy-induced hypertension. Now, the current status. What are the current status? Again, I have explained to you. I will rush through these things. Current status of diuretics. Amongst all the diuretics, we use hydrochlorothiazide, chlorthalidone, because it is long-acting once daily, chlorthalidone. Otherwise, hydrochlorothiazide, maximum 12.5 milligrams. If you use it as a sole agent, 25, but normally 6.25 to 12.5 because of two effects, diuresis and chronic vasodilation. and furosemide only in emergency and resistant cases. Other drugs and MRAs are used along with these to combat hypokalemia, and other drugs are not used in hypertension normally. Alpha-2 receptor agonist, clonidine, methyl-dopa, sometimes moxonidine nowadays because of long acting, but most often as the last drug of choice. Beta blockers, nebivolol, carvedilol, bisoprolol, and metoprolol. This is the order of choice, and this is never the first drug of choice in hypertension. Hypertension associated with cardiovascular diseases, yes, beta blockers are the drugs of choice. The ACE inhibitors, ARBs, they are the gems in hypertension, whether they are diabetic, renal, IHD, LVH, whatever they are, you can just closing your eyes, you can start off with these drugs. Calcium channel blockers, almost always dihydropyridines, non-dihydropyridines, that is verapamil and CCBs, in heart diseases like arrhythmias, PSVT arrhythmias, but you have to be careful. No bradycardia, the heart rate should not go below 60 because of bradycardia, heart block, never use along with metoprolol or beta blockers because they will produce heart block through two different mechanisms. So they can be combined with, they should not be combined with nitrates. DHP should not be combined with beta blockers. Not the DHP. Verapamil with beta blocker should not be there, and DHPs with nitrate should not be there. We can combine DHPs with beta blockers, nitrate with beta blockers, because it takes care of the hypertension, also blood pressure, and also tachycardia and bradycardia. Vasodilators, they are reserved for acute conditions like hypertensive crisis, urgencies, or emergencies. Now here, with each drug, where do they stand and where they are preferred? With little bit of reason, I would like to stress upon so that that remains in your memory whenever you add it or whenever you think or whenever somebody comes for a second opinion. Now start with ACE inhibitors because they are the drugs. They are preferred almost in all the cases. Why in development? Why in diabetes mellitus? Because they will prevent the progression of CKD, okay, both glomerulopathy as well as glomerulosclerosis, and they are protective to the heart through various mechanisms. In renal diseases, they prevent totally, if you treat them most earliest, they may not go to kidney disease at all. Next, in ischemic heart disease and LVF, especially immediately after post-MI. After acute, when you switch on to oral, start with metoprolol, which will improve ventricular function and reduce morbidity and mortality. And on a long run, the other three factors are also improved, that is fibrosis, remodeling, as well as apoptosis. Then they are always used in combination because it enhances the efficacy of diuresis, and small dose increases the improvement of anti-hypertensive efficacy of ACE inhibitors. I told you mechanism of action in one way, then combats the adverse effects. So hyperkalemia is also a problem, hypokalemia is also a problem. So combination of these will bring a large amount of normal potassium level where you need not bother very much. But still, as a warning, you should tell patients, don't eat big banana. Don't take coconut water. These two are very high in potassium. So they may land up in drug-induced hyperkalemia when they are using ACE inhibitors, coconut water, and banana. Tell them enough of your life you have spent in coconut water and banana. Now you stop. God has told you to stop. So stop those two and be on these drugs to have a near normal, good quality of life. Okay, so next, what are the compelling indications for antihypertensives? With regard to ACE inhibitors and ARBs, I told you anything and everything under the sun. Heart failure, LVH, CAD, post-MI, post-stroke, CKD, DM, microalbuminuria, prevention of atrial fibrillation indirectly. Calcium channel blockers, that is DHPs, LVH, angina, stroke, DM, atrial fibrillation, non-dihydropyridines, that is verapamil. Which are the four main heart rate lowering agents? First is beta blockers, metoprolol, mainly. Second, CCBs, verapamil. Third, digoxin. Why it has come to third place? Because of narrow margin of safety. Okay, narrow margin of safety, and itself can produce arrhythmias. Fourth is ivabradine, which will block the funny channels and then decrease the heart rate. So, four, we will get it in your PG exams. 4 heart rate lowering agents. Very, very fond of this word. heart rate lowering agents, beta blockers, metoprolol specifically, then verapamil, then digoxin, then evaporative. Okay, diuretics will prevent stroke, heart failure, high risk of CAD, and beta blockers stabilize heart failure, CAD, and post-MRP. Now, where do we prefer? We prefer in all these conditions for AC inhibitors and ARBs, which I told you. We'll come to this last. Here, now, coming to the drugs which should be avoided or which is preferred in certain of the cases. Now, I have already given you the reasons. One more small revision. In angina pectoris, we use beta blockers, that is long-acting, along with long-acting DHP, that is nifedipine, amlodipine. Why? They will decrease the blood pressure by various mechanisms and also combat the heart rate. Beta blockers will decrease heart rate, DHPs will increase heart rate. So bradycardia, tachycardia, it is combated, and heart rate is decreased, cardiac output is decreased, decrease in BP. Whereas long-acting, they will decrease the afterload, so arterial blood pressure is decreased. So combination is preferred. But drugs to be avoided, verapamil, avoid. Beta blockers in variant angina, unstable angina, avoid. Vasodilators in acute attack, avoid. Okay. So in these cases, avoid these drugs, but you can use this combination. In CHF, 3 anti-mortality drugs, AC inhibitors, ARBs, CCBs, DHP, beta blockers, plus diuretics. Don't use verapamil. Heart is already in failure. It goes to further failure. Don't use don't use beta blockers. Now, beta blockers are used because of their anti-mortality action. In cardiac arrhythmias, tachyarrhythmias, bradyarrhythmias, heart block, CCBs and beta blockers are preferred. Don't use DHP CC blockers. DHP blockers are not used. Other associated conditions in diabetes mellitus, most of the cases AC inhibitors, diabetes mellitus, bronchial asthma, gout, obesity, gout, thiazides, hyperuricemia, bronchial asthma, beta blockers, beta 2 receptors, bronchospasm, diabetes mellitus, beta blockers, hyperglycemia, thiazides, hyperglycemia. Obesity, beta blockers, it is lipid friendly, increases weight, thiazides, hyperglycemia, increases weight. Migraine, along with propranolol, CCB, ACB. Propranolol, here it is flunarizine, and AC inhibitors, question mark. Raynaud's phenomenon and PVD, don't use alpha you can use alpha blockers and CCB because they cause vasodilatation. Beta blockers are contraindicated in PVD because they cause vasospasm. Hypokalemia, all these drugs will produce hypokalemia. All these drugs are preferred in hypokalemia. Don't use thiazide like loop diuretics. Hyperkalemia is there. In case of hyperkalemia, it is a reverse. Osteoporosis, thiazides are known to produce osteoporosis, and thiazides are known to increase calcium levels. So we can use thiazides, but loop diuresis causes hypocalcemia. Do not use them in patients with osteoporosis. The next one, these are some of the doses. Because why did I put this slide is only one reason. We have seen patients with metoprolol 200 mg, which is the antiarrhythmic action rather than antihypertensive. With 12.5 to 25, the heart rate and hypertension with comorbid is more than sufficient, and it works wonderfully. There is no adverse effect, no bradycardia, no drug-induced heart block or bradycardia admitted to casualty. Nothing of those things are seen if you do those things. So that's the reason why I put this slide with the dose, initial dose and maintenance dose. Just to remember and see that you memorize whenever you are in front of the patient. You can keep it on the table itself if you don't remember it properly. The next, some of the drugs which has to be avoided, that is combination which increases toxicity. AC inhibitors with potassium sparing diuretics, that is spironolactone, eprilone, etc. Don't combine. Hyperkalemia may occur. And when beta blockers, when combined with verapamil and diltiazem, bradycardia or heart block can occur. The reasons I have told you enough. If you want, once again, I'll definitely tell you. But I hope by this time, you people all have got more memory than me, and you can really give the reasons. Combination which antagonize the effect, clonidine with alpha blockers. Clonidine is alpha 2 agonist, and you use alpha blockers antagonism, and beta blockers, clonidine effects are indirectly blocked with this, and withdrawal reactions are more seen when you combine clonidine and beta blockers, because both of them have withdrawal phenomenon. Clonidine, hypertension or cheese reaction, as beta blockers, withdrawal phenomenon, they may go to hypotension completely or withdrawal hypertension. No synergistic effect, clonidine, methyl dopa, same target, it will have only additive effect. Synergistic is 1 plus 1 is 3, whereas additive is 1 plus 1 is 2. DHP, CCBs and hydralazine both are vasodilators and all or alpha blockers, and all of them are known to cause tachycardia. So for that you have to be careful. Now, what is the, I think one more we had, we'll see in the later one. Next, how do we really treat? Step 1, I think all of you know this. Initially, we start with ACE/ARB or CCBs. Step 2, we combine 2 plus 1 plus 2 or 2 plus 3. Step 3, all the 3. Step 4, you combine with aldosterone antagonist. Potassium level should be seen in both of them. If you don't want aldosterone antagonist and it is more than 5.5, then add a beta blocker or a alpha blocker. The choice is between aldosterone, beta blocker, alpha blocker lately, whereas you should play with ACE, ARB, CCB and diuretics in the initial stages, but you should tell the timings. If somebody takes at 10 o'clock in the morning and 8 o'clock or 6 o'clock in the evening or 12 o'clock at night, it won't work. All antihypertensive drugs, chronopharmacology is a must. You should tell them timing. They'll say after food, before food, in between food, later. I'll go for a trip, how to maintain timing. These are the things. So you should tell them nothing doing, you have to maintain timing. Even if you are fasting, you take it at correct timings, 12 hours gap between two doses. Now, as I told you in the previous, the selection of drugs, especially with various others, the slide has gone little that side, this side. I'll try to make it up. In case of secondary hypertension, you treat the cause, the BP will come on its own. Don't be afraid and start treating hypertension, which goes to hypotension. So treat the cause, any endocrine causes, any renal causes, any congenital causes like coarctation of aorta, etc. Treat the hypertension. The normal, treat the cause, normal hypertension will come back to normal as such. Don't be afraid. The second, drug induced. Many drugs are known to cause hypertension. Corticosteroids, magic drug. People will keep on using these drugs. So be very careful. NSAIDs, left and right, because it is there, over-the-counter drugs. Estrogens, especially in females, as creams. Hormone replacement therapy. Postmenopausal osteoporosis. All these estrogens are used. So this is the culprit to produce even coronary artery thrombosis. Vasoconstrictors, which will increase blood pressure. So discontinue these, the hypertension is controlled automatically. Next, idiopathic. Idiopathic or primary hypertension. We saw in the previous slides how to choose the group according to the guidelines or according to the age or according to the areas. But primary with comorbid also we saw you use similar to the above guidelines, but with precaution. As I told you, patients with gout, don't use thiazides. Patients with hyperglycemia, don't use thiazides. No, even if they have all the other things, the choice will be AC inhibitors or ARS, like that. So you should know where to use and where not to use. Next, same things, if they have mainly cardiovascular diseases like angina, CHF, then PSVT, then you should be quite careful where to use and where not to use, which combinations to use. And in diabetes mellitus, asthma, gout, obesity, migraine, dyslipidemia, hypohyperkalemia, I told you just now what are the drugs to be used and avoided. Hypertension in pregnancy, only 4 drugs. Never think of other drugs. And that too in this order only. Labetalol, amlodipine, labetalol, alpha and beta blocker, amlodipine, L-type calcium channel blocker in arteries. Then next is alpha-methyl dopa, centrally acting. And lastly, hydralazine, directly acting vasodilator. These are the only 4 drugs which we can use in preeclampsia. Next, in isolated systolic hypertension, elderly, per se, no problem CCBs, but with comorbid, as I told you in the previous slides later. Hypertensive crisis means both urgencies as well as emergencies. E for end organ damage. If they come with 180 by 110, with you check for eyes, ECG heart, serum creatinine in kidney, or even carotid intima thickness, whatever it is, When you check and you find some other thing, then it becomes hypertensive emergencies. No organ damage, it becomes hypertensive urgency. In both the cases, the treatment is the same. The order of drugs of choice are sodium nitroprusside, bar nicardipine, bar clevidipine, bar furosemide, depending on the condition. Then later on, enalapril, okay, and then other drugs like we can use all the drugs which can be used, IV, clonidine, all these drugs can be used whenever we can give, and it should be only IV drugs, not the this one. And most often we prefer these are the drugs which are given IV, especially sodium nitroprusside, nicardipine. All these are given by IV infusion. So we phenoldopam, glyceryl trinitrate, all these are given by IV. We prefer giving IV bolus like labetalol or even phentolamine or diazoxide, enalaprilate, labetalol. All these are the drugs which we prefer giving IV and then monitoring it so that the BP is controlled, and see to it that every hour or every 1 to 4 hours, 20 millimeters of the blood pressure is decreased. Don't decrease completely. There may be after effects. So you have to be careful in these cases. And these are about 8 drugs which we use in hypertensive crisis. I will I'll tell you about pulmonary hypertension in my last 2 or 3 slides. Now, coming to resistant hypertension, when do we call it as resistant hypertension? We call it normally in hypertension, they come and land up in 2 or 3 drugs with optimum doses, which act by different mechanisms, and they try to remain in those cases. But even after 2-3 drugs, the blood pressure will be still high above 160/100. If it is around 150/100 and all those things, don't bother too much. Tell them to keep on recording and adjust those 4 drugs according to the need basis. They will become all right. There is no problem at all. But if it is persistently high, above 160/100 or 150/100, 110, then you think of adding the 4th drug. So if there is more than 3 drugs, one of that one is diuretic and it is not in control, then they are labeled as resistant hypertension, and we add mainly clonidine, or basically we add clonidine. If not, we add beta blocker or alpha. Clonidine or other vasodilators, and lastly we add either alpha blocker or beta. So now coming to drugs for PH, pulmonary artery hypertension. In severe cases, we use epoprostenol and treprostinol. All these are prostaglandin analogs. You should remember, prostaglandin analogs means from phospholipid, there will be cyclooxygenase pathway and lipooxygenase pathway. In cyclooxygenase pathway, you have all prostaglandins. The intermediate ones are PGH2 and PGG2. They form further PGI2, E2, F2 alpha, and TX8, where they are clinically used in various conditions. Amongst them, PGI2, that is epoprostenol, and treprostinol is used in severe cases of pulmonary hypertension. In moderate cases, we use this endothelial receptor antagonist. The most fond ones were Posenton, ambrisentan, and mesenteton. But nowadays, we are very fond of PDE inhibitors, sildenafil, but this should not be used with other drugs because of severe hypertension, tadalafil and vardenafil. The latest one is SGC stimulator, riociguat. Now we have started using nitric oxide donors also along with CCBs because they are vasodilators, and even pulmonary vasodilatation is most wanted so that we don't land up in any of the pulmonary complications. And most fancy thing nowadays is pulmonary surfactant. These are the ones which are used in hospital setup along with Fasudil, which is a Rho kinase inhibitors, where we use this Rho kinase inhibitor even in glaucoma. Now, lastly, a glimpse about vasoactive peptides. The normal ones which are seen in our body are vasoconstrictor, as I told you, angiotensin 2, that is which are vasoconstrictors are angiotensin 2, and arginine, vasopressin, AVP, ADH, endothelins, neuropeptides, and neurotensin. To combat them, we have bradykinin, which is a vasodilator, which we saw which will be stimulated by ACA enzyme. Then natriuretic peptides, which we are very fond in heart diseases, where we try to find out what is the rate of CCF and MI and see that prognosis. VIP in endothelians, then CGRP and adrenomedulin, and neurotensin SP as well as neurotensin. These are to give you a glimpse. I have given this slide. So these are the same things what we did it previously. I think I have to scrape off these things. Now, what is the current status? This is very important slide. What you have to remember: centrally acting drugs, name them: clonidine, moxonidine, alpha-methyl-dopa, rarely used. Nifedipine, labetalol has come instead of alpha-methyl-dopa in PIH. Non-cardiovascular condition as anesthetic adjuvant, clonidine, more than as an antihypertensive. Why? Because of withdrawal phenomenon, cheese reaction, rebound hypertension, sleep, drowsiness. Okay, because of all these phenomena, clonidine has become the last drug and used in resistant hypertension. Non-cardiovascular conditions are many. The one which is more important is anesthetic adjuvant, where we give it even epidural along with morphine for anesthesia. Beta blockers are no longer recommended as first-line drug unless there is some compelling indications like MI, arrhythmias, cardiomyopathy, then angina, etc. Then no compelling indications. The best drugs, ACE inhibitors, ARB, CCB, thiazides as first line, alone, solo, or in combination, and MRA, alpha, beta blockers in case where potassium level, depending on potassium level as 4 drugs, are also in resistant hypertension. Directly acting vasodilators only in emergencies or urgencies. Why? Because of fear of tachycardia, sodium and water retention. So you have to use for tachycardia beta blocker, sodium and water retention, diuretics. So we are aiming at one drug and going for 3 drugs, which is really ridiculous. So these drugs are never used. They are used in acute conditions so that you can tide over the crisis as quickly as possible. Thank you very much for your patient hearing. If you want any of the drugs in detail, definitely I will tell you, because we have got 2 more classes in cardiovascular diseases. You just tell me which are the ones. I will definitely tell about them in detail. I thought this will be more than sufficient. And I just want 5 MCQs, 2 more minutes. That's all. Okay. The first question, if anybody can answer, I'll be the most happiest. I'll just give you just 30 seconds and I'll start answering. Mark the wrong match about antihypertensive drug and its mechanism. I'll tell the 4 drugs and also the mechanism. You say whether it is right or wrong. That's all. Clonidine, central alpha 2 agonist. You can type it so that it comes here on the screen. Alpha 2 agonist. Match it, whether it is right or wrong, depending on mechanism of action. It is right. Hydralazine, directly acting vasodilator. Right. But fear of SLE. Amlodipine, calcium channel blocker. DHP, calcium channel blocker. Arterial vasodilator. Tachycardia is the main problem. And some of the people will get nifedipine, amlodipine. If they're sensitive, they get gum hyperplasia. That is one of the 3 drugs which produce gum hyperplasia in pharmacology is nifedipine, second, cyclosporin, third, phenytoin. Cyclosporin, very common because we are using it as an immunosuppressant and also in organ transplantation. So because they produce hypertension seizures, we have shifted on to other immunosuppressants like MMF and other things. But cyclosporin was the drug which was used. They cause hypertension, seizures, and gum hyperplasia. Now we have stopped using cyclosporin. Losartan AC inhibitor. No, losartan is a ARB. Okay, I hope you have understood. Which is the following drug preferred in the treatment of hypertensive emergency? Nicardipine, spironolactone, enalapril, propranolol. Hypertensive emergency. E, end organ damage. F, U, no end organ damage. Nicardipine, yes, as an IV infusion. Enalapril, you have to have enalaprillate prodrug. Enalapril is given only orally. Propranolol, though we can give IV, it has got so many adverse effects, ABCD, mainly clinically seen, so we don't use it. So, and also bradycardia, that's the main problem. Spironolactone, it's a mineralocorticoid receptor antagonist. It may cause hyperkalemia. Orally, it is available, not IV, mainly used in primary aldosteronism. Next, which of the following antihypertensive drug is avoided during pregnancy? Labetalol, lisinopril, alpha-methyl-dopa, nifedipine. All are drugs used in PIH except lisinopril because teratogenicity is renal agenesis. Don't stop at teratogenicity. That's a common word you have to specify. That is renal agenesis. Phenytoin, fetal hydantoin syndrome. Okay, thalidomide, phacomalia. Chloramphenicol, gray baby syndrome. Tetracycline, growth retardation, discoloration of teeth. You should specify. Don't just say teratogenicity. All of the following drugs are used in pulmonary hypertension except sildenafil, epoprostenol, phenoldiazepam, bosentan. The drug is phenoldiazepam, which is used in hypertensive emergencies. All the three are used in PAH. Which of the following antihypertensive causes sedation? All drugs which are centrally acting produce sedation, whether they are anesthetics, sedative hypnotics, anticonvulsants, whatever they are. If they are centrally acting, they produce sedation. Otherwise, no problem. That is clonidine, candesartan, hydralazine, amlodipine. Clonidine, centrally acting alpha-2 agonist, produces sedation. Candesartan, ARB, no. Hydralazine, directly acting peripheral vasodilator, no. Amlodipine, DHP, L-type calcium channel blocker, does not produce sedation. All of the following statements are correct except, so you should match again. Hydrochlorothiazide is suitable agent in hypertension in patients with osteoporosis. Okay, is it? Next, lisinopril is considered as first-line drug in hypertension. Correct? Yes. Prazosin is preferred in hypertension in patients with prostatic hypertrophy. We use prazosin, but normally tamsulosin. Propranolol is preferred in patients with diabetes. No. So all of the following statements are correct, except propranolol is preferred in hypertension in patients with diabetes. No, because beta-2 blockade will cause hypoglycemia unawareness. So don't use propranolol. Use low-dose cardioselective or vasodilatory. If you use higher doses, the receptor selectivity is lost. These are few of the things to stimulate your brain or to just confirm whether I have done the session correctly or not. Thank you very much.